Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Today I will talk about headache. The objective of this lecture is to approach to a patient with headache and details of its common causes and to list an appropriate treatment for each type. The term headache describes pain in the region of the cranial vault, while pain in the maxillary or mandibular region is classified as facial pain, although the line of demarcation is often vague. The pathophysiology of the headache. The headache is caused by traction, displacement, inflammation, vascular spasm, or distension of the pain-sensitive structures in the head or neck. While the isolated involvement of the bone skull, most of the dura, or most regions of the brain parenchyma doesn't produce pain. Headache result from disorders that affect pain-sensitive structures of the head and neck, as we said, such as meninges, blood vessels, and muscles. Approach to diagnosis. Our goal is to arrive at an accurate diagnosis for primary or secondary etiologies. History. Temporal. The important elements of history include: first, temporal pattern of headache. Temporal profile of the headache includes onset, duration, and the course. Headaches, according to the temporal evolution, is divided into sudden, acute, subacute, and chronic headaches. Actually, the chronic headaches tend to be primary, while new onset headaches are usually secondary. Location. Headache location can suggest involvement of local structures. For example, temporal pain in giant cell arteritis. Ocular or retroocular pain suggests a primary ophthalmological disorder, such as acute iritis or glaucoma, or optic nerve disease like optic neuritis, but it is also common in migraine or cluster headache. Occipital localization can also occur with meningeal irritation from infection or hemorrhage and with disorders of the upper cervical spine. 3. The pain character, like dull, throbbing, and tightness. Pulsating, throbbing pain support the diagnosis of migraine. A steady sensation of tightness or pressure is also common seen with tension headache, while pain produced by intracranial mass lesion is typically dull and steady. 4. Prodromal symptoms, associated phenomena, and the chronological evolution. The manifestations of the underlying systemic disease can aid in the etiologic diagnosis of the headache and should always be sought. So, recent weight loss may accompany cancer, giant cell arteritis, or depression. Fever may indicate systemic infection or CNS infection, while visual disturbance suggests an ocular disorder and migraine. 5th, precipitating and exacerbating factors can provide a guide to the cause of headache. So, precipitation of headache by alcohol is especially typical of cluster headache. The use of oral contraceptive agents or other drugs like nitrates may precipitate or exacerbate migraine. The discomfort exacerbated by rapid change in head position or by events that transiently raise the intracranial pressure, such as coughing, sneezing, and is often associated with an intracranial mass headache, but can occur in migraine, while anger, excitement, or irritation can precipitate or worsen both migraine and tension headache. Relieving factors. The effects of specific postures or activities include effects of medication, we mean painkillers. 7th, history of headache. The characteristics of the present headache should be compared with those of previous occurrences. The severity is less important than quality in distinguishing a new headache from an old headache. The single most important question when developing a differential diagnosis for headache is the question: is this headache new or old? Also 8, past medical history, drug history, and family history of like migraine and seizure. Now, physical examination. A general physical examination is mandatory since headache is a non-specific accompaniment of many systemic disorders. If possible, the patient should be observed during an episode of headache. Examination should consist of vital signs, blood pressure, temperature, and pulse rate. Chronic hypertension is often raised mistakenly as a cause of headache. Hypertension per se rarely causes headache unless the blood pressure elevation is acute, paroxysmal, as with pheochromocytoma, or very high, as with early hypertensive encephalopathy. Subarachnoid hemorrhage is commonly followed by marked acute blood pressure elevation. Neck examination. Cervical muscle spasm occur with tension headache, cervical spine injuries, cervical arthritis, and meningitis. Meningeal irritation signs must be carefully sought, especially if the headache is of recent onset. Usually, meningeal irritation causes neck stiffness mainly in the anterior-posterior direction, whereas cervical spine disorders restrict movement in all directions. Mental state examination. Dementia may be the major feature of intracranial tumor. Cranial nerve examination. The papilledema, which is the hallmark of increased intracranial pressure, may be seen in space-occupying lesion or pseudotumor cerebri. Neuroimaging. The strong indication of neuroimaging in headache. First, any headache patient in whom neurological examination discloses an abnormal or an abnormality should undergo further studies. Second, when the neurological examination is normal, no further studies are indicated except when there is an element of history suggests a specific diagnosis like epilepsy or brain tumor, the headache have developed a new quality or have become intractable to treatment, the history of systemic disease like malignancy or endocrine dysfunction, headaches of sudden onset, persistent or increased vomiting, headache triggered by maneuvers that increase intracranial pressure, such as coughing, sneezing, and straining at a stool, and the headache is maximal on awakening from sleep. Classification and differential diagnosis of headache. The headaches according to the temporal profile are divided into headache of sudden onset. We will give example for each one, for each type of onset. Sudden onset like subarachnoid hemorrhage, intracerebral hemorrhage. Headache of acute onset like meningitis or encephalitis, seizure, hypertensive encephalopathy. Headaches of subacute onset like intracerebral mass, pseudotumor cerebri, giant cell arteritis. And lastly, chronic headaches like tension type headache, migraine, cluster, and others. While if we classify headache according to the etiology, it can be divided into primary and secondary. In a primary headache disorder, the headache itself is the illness and no other etiology is diagnosed. While in the secondary headache, the headache is the symptom of an identifiable structural or functional abnormality. Now we will talk briefly for certain types of headache. Hypertensive encephalopathy. This is a complication of malignant hypertension. The blood pressure usually of 250/150. The pain is described as throbbing. Other signs of diffuse or focal central nervous system dysfunction are present, such as hemiparesis or focal seizures. Treatment with antihypertensive drugs, but care must be taken to avoid hypotension. Giant cell arteritis. This disorder, also known as temporal arteritis, it is characterized by subacute granulomatous inflammation that affects the external carotid arterial system. This syndrome, which affects women twice as frequently as men, it is uncommon before the age of 50 and is frequently associated with non-specific signs and symptoms such as malaise, myalgia, weight loss, arthralgia, and fever. It is characteristically localized to the scalp, especially over the temporal arteries, scalp tenderness. The pain or stiffness in the jaw during chewing, which is called jaw claudication. It is highly suggestive of giant cell arteritis and is due to arterial ischemia in the muscles of mastication. The involvement of the ophthalmic artery leads to the permanent blindness in 50% of untreated patients. In half of those patients, blindness will become bilateral. The diagnosis is made by biopsy of the affected temporal arteries, but as you know, the biopsy, the temporal arteries may experience a feature of or a phenomenon of skip lesion. So the erythrosedimentation rate is almost invariably elevated. Therapy for giant cell arteritis is prednisolone. Intracranial mass headache. This headache associated with brain tumors, often non-specific in character but typically dull and steady in nature. It may be bifrontal or may be bioccipital. It is exacerbated by coughing, sneezing, and straining. It is usually maximal on awakening in the morning and is associated with nausea and vomiting. Low intracranial pressure headache. It has a higher incidence than high intracranial pressure. The most common cause of low intracranial pressure is iatrogenic. This means it is made by medical staff or doctors, which is following lumbar puncture or spinal anesthesia. Spontaneous intracranial hypotension is usually the result of spontaneous CSF leak within the spinal canal. The main feature of low CSF pressure headache is bitemporal pressure or heaviness that is completely or near completely relieved by lying flat. The oral symptoms, we mean symptoms related to the ear, such as muted hearing or non-pulsatile tinnitus, commonly accompany the low pressure state. Now we talk about pseudotumor cerebri. It is characterized by a diffuse increase in the intracranial pressure, causing headache and papilledema. Diplopia may also occur as a result of abducens nerve palsy. The course of the idiopathic disorder is generally self-limited over several months with no sequelae if intracranial pressure is maintained at a relatively normal level to prevent secondary optic atrophy. Differentiating idiopathic pseudotumor cerebri from intracerebral mass lesion and from the disorder is critical. So here the image is usually normal in pseudotumor cerebri, and there is no evidence of intracerebral mass. Treatment with acetazolamide is but in other instances topiramate, steroid may be necessary. Refractory cases, repeated lumbar puncture or lumboperitoneal shunting procedures are protect vision. Now what about a headache due to seizures? The post-ictal headache that follows generalized tonic-clonic seizures is usually never preceding the seizure. It is mandatory to be post-ictal, post-seizure. Now we will talk about the primary headaches, and we take examples for certain types. First, the most common headache in societies is the tension type headache. It is a chronic disorder that begins after age 20. Women are more commonly affected than men. The main pain features of tension headache are bilateral location, squeezing, non-pulsating quality, mild to moderate intensity, and lack of aggravation by routine physical activities. Tension headaches are seldom disabling. The pain is sometimes likened to a tight band around the head, and it may be bilateral, bioccipital head pain that is not associated with the vomiting or prodromal visual disturbances. The acute attacks of tension headache may respond to acetaminophen or non-steroidal anti-inflammatory drugs, and for prophylaxis purposes, the amitriptyline, which is tricyclic antidepressant, is the only proven treatment. Migraine is an episodic recurrent headache disorder manifesting in attacks lasting 4 to 72 hours, which can be classified into common and classic. What about the pathophysiology? The intracranial vasoconstriction and extracranial vasodilatation have long been held to be the respective causes of the aura and then the headache phases of migraine. Migraine attacks can be precipitated by certain foods, fasting, motion, menses, drug, especially oral contraceptive and vasodilators such as nitroglycerin, and the bright light may also trigger attacks. We have two types of migraine: migraine with aura, which is called classic migraine, and migraine without aura, which is common migraine. What about the classic migraine? It is headache preceded by transient neurological symptoms, the aura. The most common auras are visual alterations, particularly scotomas and scintillating visual disturbances that enlarge and spread peripherally, last for about 20 minutes, followed by throbbing unilateral headache. The frequency of headache varies, but more than 50% of patients experiences no more than one attack per week. Remissions are common during the second and third trimester of pregnancy and after menopause. Although hemicranial pain is hallmark of classic migraine, headaches can also be bilateral. During the headache, prominent associated symptoms include nausea, vomiting, phonophobia, irritability, and lassitude. Migraine headaches are frequently relieved by darkness, sleep, getting vomiting, or pressing on the ipsilateral temporal artery. While the common migraine, the headache lacks the classical aura and is usually bilateral and periorbital, and is seen more frequently in clinical practice. The pain may be described as a throbbing, and the vomiting may be occasionally terminate the headache. Treatment of the migraine. The treatment of the migraine can be directed toward abortion or aborting the acute migrainous attack and toward the prophylaxis. The acute migraine attacks may be responded to simple analgesics like acetaminophen, aspirin, or other non-steroidal. Other drugs, triptans, narcotic analgesics, ergot preparations, and the antiemetics may be necessary. While there is indication for prophylactic treatment are 4 or more headache episodes per month, acute medications ineffective, contraindicated or overused, and lastly, adverse effects from acute medications. We have classes of migraine preventives, which are structurally unrelated agents. These anti-epileptic drugs, antidepressants, beta-adrenergic blockers, calcium channel antagonists, non-steroidal anti-inflammatory drugs, and we have others like norepinephrine, serotonin reuptake inhibitor like venlafaxine, antihistamine, which called also calcium channel blocker, which is flunarizine, B2, vitamin B2, riboflavin, and Botox A, and lastly candesartan, which is classified as angiotensin receptor blocker. Finally, we talk about the cluster headache. It is a common headache syndrome seen much more frequently in men than in women. It is characteristically begin at the later age than does migraine, with a mean age at onset of 25 years. The syndrome presents as clusters of brief, very severe unilateral, constant, non-throbbing, please concentrate, non-throbbing headache that lasts from a few minutes to less than 2 hours. Also, duration is important. It is less than the duration of migraine. Clusters are always unilateral and usually recur on the same side in any given patient. The headache commonly occurs at night, awaken the patient from sleep, and recur daily, often at nearly the same time of day, for a cluster period of weeks to months. Between clusters, the patient may be free from headaches for months or years. What are the commonly associated features of cluster headache? They are ipsilateral conjunctival injection, lacrimation, nasal stuffiness, and Horner syndromes. The episodes are often precipitated by use of alcohol or vasodilating drugs. At the onset of the headache cluster, the treatment involves measures both to abort the acute attack and to prevent subsequent ones. The acute relief of pain within minutes may be achieved by somatriptan, by somatriptan, 100% oxygen, or dihydroergotamine. A dramatic improvement is typically seen with administration of prednisolone 40 to 80 mg per day orally for 1 week, discontinued by tapering the dose over the following week. The pain may resolve within hours, and most patients who respond do so within 2 days. Here is a table for the types of other primary headaches, 8 types, and the indomethacin drug is the drug for the first 6 of this type of headache. Thank you.